remember, there are multiple techniques to treat leg veins. So we talk about sclerotherapy very often, but we do have other ways in which we can treat. Long pulsed Nd:YAG lasers, I'll talk about that shortly. Diode lasers are a good way of managing telangiectasia and even slightly larger reticular veins to a certain extent. So choose, we'll talk a little bit about the choices and how we make that choice. Obviously, manage client expectations. One of the common things I see when people come in is a very wide distribution of people. People will have very, very large telangiectatic webs on the leg, which are very blindingly obvious from the other side of the room. And then some people will come in and they'll have things that I have to get my magnification lenses out for to just see and say, this is a real problem. When you start to get that type of person asking for improvement, you're probably only going to do worse than what they've got already. So don't try and risk treating things that are barely visible. That's just, you're basically getting involved with sort of body dysmorphic individuals, basically. All right? So you need to be able to deal with complications of your treatment as well. So in focus, we need to, with sclerotherapy, look at the equipment, technique, client selection, optimizing results using laser. We need to use the appropriate wavelength, appropriate parameters, and know when to use them. So literally, this talk was given to sort of highlight things that I commonly see that aren't done in sclerotherapy and laser that can be done to better the results. So things in yellow are effectively things that we can do to make our practice better. So 2 ml syringes when we're injecting sclerosant are important because very often I've seen this procedure done with a 1 ml syringe, and what happens is the extrusion force that you are effectively creating with a 1 ml syringe is very, very large, and small telangiectasia in the leg will often blow out or be damaged, and then you can get bruising, post-inflammatory hyperpigmentation, other problems from that, just because you're causing more damage to the vein than actually contracting it and sclerosing it and closing it down. 32 gauge needles are useful. They can be obtained. They're not very easy to obtain, but finer telangiectasia and webs can be treated with 32 gauge needles. Sclerosant concentration, here is an important thing as well. Lots of people will think in their mind when they're treating veins, let's just go for something a little bit higher. It will make sure we shut down the vein adequately. The sclerosants commonly used in the UK are polydocanol, or its trade name is Sclerovane, and sodium tetradecyl sulfate, which is STS, or sometimes known as Fibrovane. Sclerosants' properties vary, and they are locally chemotoxic to tissue as well. So if you extravasate sclerosant when you're injecting it into leg veins, what's going to happen is you can get localized tissue damage and ulceration. So I would say it was a much safer way to proceed to use the minimum effective sclerosant concentration to get the result you want. Now, with veins of probably up to 1 millimeter in width, you can very easily get away with a 0.5% polydocanol. 1% is more useful when you're injecting larger feeder vessels or reticular vessels that are feeding these webs, and that is when you would probably use the 1%, and you would use it with aspiration as well, so to make sure you have nice placement of the needle tip in the vessel. Pressure is very important. This is something that's commonly omitted or a bit neglected sometimes in the practice of sclerotherapy. Very interestingly, veins always want to recover. Facial telangiectasia, leg veins, they will do their best to recover from an insult. So basically they're trying to make our lives difficult. So clotting is our enemy. What happens when we're injecting a sclerosant into a vein is that effectively you're damaging the wall of the vessel and the endothelium of the vessel, and also causing it to go into vasospasm. When that happens, the fibrosis sort of develops and it seals that vein shut and it scars together effectively. Now, the vein's response to this, when this insult of sclerosant passes through it, is to develop a clot. The clot will bridge the vessel open, and then adjacent areas of healthy endothelium will mediate a recovery to that vessel. So when sclerotherapy fails, or treatment of facial telangiectasia fails, for example, lasers, it's because not adequate vessel damage has been done, and the vessels have basically healed themselves and defeated the objective of your treatment. So compression will actually help to immediately obliterate the lumen of the vessel, stop clot development, and increase the success rate of your treatment. So it shouldn't be taken lightly, because often people will have treatment and they'll be off on their way, but they should have bought class 1 or class 2 compression stockings to their treatment and be putting those on immediately after the treatment. There's a little caveat to this, because obviously you're injecting something that's vasoconstrictive in an area, and if you're injecting it quite superficially and you put too much compression or a dressing between the stockings, you can, and I've seen this on a few occasions, get superficial dressing, sort of epidermal dermal necrosis problems. So don't get over enthusiastic with compression, but a nice uniform compression with tights is going to help your outcome and success. This is a typical sort of set tray of equipment that we use to just perform it. As you can see, it's very simple, nothing complex here. I'm surprised when I speak to a lot of my colleagues why they don't do it more often, but you know, it's just an easy thing to do. Environment, well, light sources. Very often people will use assistance and various light sources. Now, with sclerotherapy, you need to see a good contrast. So using very, very bright light sources or taking photos with flashes, you often just white out the detail. These days we can actually get cross-polarized light sources that will actually help us do some subsurface viewing and see telangiectasia and webs more easily under the skin. They are useful tools in helping to inject smaller and finer vessels. The comfort of the patient is important, because it's a very fine injection procedure. These are very small targets, you're using very small needles, and the veins are almost the size of the needle. So if you don't make sure the patient is comfortable and not moving around, and if you are not comfortable and you're sort of bending over and trying to hold your body position one way, you'll fail with your injections and you won't give them a good result. Obviously, with sclerotherapy, result is dependent on cannulating the veins. Safety goggles, very often because of the superficial nature of the injection, the bevel of the needle is half out, so getting fluid going directly out of the bevel, almost inevitably always hitting your eye, is a problem in sclerotherapy. So always wear protective eyewear to protect from infectious hazards. And obviously adequate couch space and adequate maneuverability around the couch as well. Now, this is what I was talking about when we were talking about client selection. This is the CEAP classification system, which was put forward in 1994 by the American Venous Forum as a universal classification system for leg venous pathology. So we deal exclusively with this category of people in the aesthetic sector. It's very obvious why we don't deal with any of the other categories. These people have more to worry about, and these people are developing more to worry about, but you need some more specialist advice for them. If you don't treat big veins first, your deeper sources of reflux, i.e. perforators, are going to be a problem. You will never get success in your treatment. Also, because of venous stasis, your likelihood of giving them phlebitis and your likelihood of giving them DVTs and clots and problems increases, because the sclerosant isn't going to be washed out of the venous system as quickly and efficiently as it would be in a healthy individual. So please, 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 the take-home message here is don't fiddle about with any of this in an effort to try and make things better. One of the common problems here is the pressure that some clients will, or patients will put on you and say, I want you to treat my visible dark veins, even though I've got blindingly large varicose veins sticking out of my leg, because the dark veins bother me more. They will put a lot of pressure on you to try and do that. You know that that's a scenario you don't want to get your hands wet with. You must get larger, deeper sources of reflux dealt with first, and then after that's been done, you can go on and manage their superficial webs. The reasons why people get veins are predominantly genetic. We know this is a high concordance in monozygotic twins, about 75%. We know that there are other reasons that can also assist in the development of veins, such as pregnancy is a common precipitating factors in development of female leg veins, occupations that require prolonged standing. These are all minor things that also contribute, but basically it's your genetic inheritance that's going to cause a problem. So you know, correct ideas when you're treating these patients, because patients often have the wrong ideas of why they've got venous problems. And make sure you have adequate time to do the treatment. Don't rush it, because it's going to be quite a meticulous thing that you have to do to give a patient a good result. And don't start when you're starting with sclerotherapy to try and treat veins that you can barely see, because what's going to happen, they're going to get all the side effects of sclerotherapy, pigmentation problems, they're going to get new, what we call telangiectatic mats, which is a process of neovascularization that occurs after insult to vessels, and they'll just come back and say, well, I didn't have very large vessels to start with, now everything just looks worse. This is what you want to be treating first. Things like this, where you're going to make a big difference. If you are trying to inject things that look like this, you're just asking for a world of trouble. So you know, don't try and be a solution to everyone's problem. One of the things I don't see done very commonly in sclerotherapy in the aesthetic sector is that people just inject what they can see. They see these purple veins I showed you, they inject those, and that's it. But deeper sources of reflux are missed, so people will get recurrence very quickly. Another thing that doesn't seem to be done either is when the larger veins are injected, clots that do develop, even despite the fact that you're using compression, are not drained, and that leads to slow healing of the areas that have been injected. And we've talked about compression. So feeder vessels, it's a bit difficult to see with all this light, but you can probably see what looks like a little bit of a tree-like pattern here. This is a sort of typical lateral venous system starburst telangiectasia pattern that you often see on the side of women's legs. And here you can see, I don't know whether you can see, but you can see there's a reticular feeder vessel that is that better? Can you see my laser tracking up that vessel there? Yeah. So very often I see people who just get stuck in, inject, 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 all the way around. And this will just be completely left alone. And that is the problem, because this feeder vessel, which will feed right back down into the perforators in the back of the popliteal fossa, is going to still be a source of reflux. So even though you inject these will come back quite quickly. So you must put sclerosant into this vessel as well and prevent the whole area from forming again. So that is another important way of optimizing your treatment. Look out for reticular feeder vessels and inject reticular feeder vessels as well. And here you can see a sort of schematic representation of what we're seeing there. What is visible is basically these twigs on the end of the branch. But the branches are also important to inject. And if you look carefully, or you're aware that these exist, then you can inject them and make a better difference with your sclerotherapy treatment. That's the reason why we do it. I would do like I said, the reticular vein injections with a 2 ml syringe, 30 gauge needle, aspirate dark blood into the syringe before you inject the sclerosant, basically. So remember, we are doing unguided injections. When we're doing unguided injections, the last thing we want to do is inject arteries and arterioles and cause ischemic necrosis problems. So always, when you're injecting slightly deeper, slightly larger vessels, make sure you've got some vision and aspirate and then inject. And you're also injecting more concentrated sclerosant as well, so your risk of doing creating problems and ulcerations is greater. Microthrombi, I've just talked about how these develop following sclerotherapy, so try and drain them, because if you don't, you'll get a higher incidence of hyperpigmentation following the therapy. Hyperpigmentation is an annoyance, because it's something that, even though it will resolve in most cases, it just doesn't allow the result to be nice very quickly. So If you drain the microthrombi, if you reduce the inflammatory process around the treated vessel, this is going to give you a result much more free of problems like post-inflammatory hyperpigmentation. It also minimizes hemosiderin deposition risk, and it also tends to be quite sore and irritant to the vein. If you drain the clots, that resolves very quickly as well. So this is an example of me seeing a person 2 weeks later following their treatment. It looks a bit of a mess, doesn't it? But this black stuff is not blood from the vein. This is just coagulum that has developed in the vein. So I'll use an 18 gauge or a 21 gauge needle to just make holes over the little clots, drain them, and the resolution will be much, much faster. Compression, we've explained why we want to stop clots from forming, and this is the reason why we use compression. And obviously that will help with preventing problems such as hyperpigmentation in the long run, extravasation, and inflammation. And the reason, the way I would normally do this in the practical scenario is that when I've done the consultation, I'll ask the client to go to the pharmacy and obtain a pair of class 1 or class 2 compression stockings. If I'm doing larger veins, I'll ask them to take class 2, which is a 30 millimeter mercury compression, and use that for about 5 days. If we're just doing small telangiectasias, there's not too many larger vessels to inject, then probably a 3-day regime. Now, this is just based on what I know from treating a lot of clients and how long they can tolerate wearing compression for. It's a balance between the two, but this will certainly help optimize your result. And obviously, good post-treatment advice. Now, I'm just going to go quickly on to a little bit of laser now. Laser is something I use adjunctively in the treatment of leg telangiectasia as well. For those of you not yet familiar with laser, the way laser will work is that the hemoglobin and even the water content of the vessel will absorb the laser light. That will cause a resultant increase in the temperature. When the temperature in the vessel starts to exceed sort of 50, 60 degrees, you start to send the vessel into vasospasm, and it also causes permanent damage to the vessel and seals it as well. So it is a very useful way of treating leg veins. However, one of the problems is conventional vascular lasers that we use for example, facial telangiectasia between the 400 and 600 nanometer wavelength range, very poorly penetrating in the leg. Leg telangiectasia, by definition, are deeper, over 1 millimeter deep, and 400 to 600 nanometer wavelengths don't adequately penetrate, and all they cause is a superficial vasculitic purpura, which then just goes on to cause hyperpigmentation. I've seen this so often, pulse dye laser, KTP laser, used in the treatment of leg veins, because it's just generally accepted that those are vascular lasers, so they ought to work on the legs as well. They're actually quite a poor choice for leg vein treatment, and that is why inevitably I'll get so many people coming to say, well, they tried a little bit of IPL, they tried a bit of laser, didn't do anything, and actually it just probably made them look a little bit worse. So please, please, please think about what you're doing with lasers. Don't just choose conventional vascular lasers. It says PDL works on the face, it must work on the leg. That is not an obvious deduction, and I'll explain why in just a second. These are some of the reasons why I will treat with laser. So things around the ankle. It's very risky to inject sclerosants around the ankle. There's more AV abnormalities there that can result in ulceration. Resistance to sclerotherapy. Sometimes I'll actually use the laser to actually reduce the lumen of larger feeder vessels to make the subsequent sclerotherapy more successful. People who are needle phobic, obviously. Hypercoagulable state, which is a big contraindication to sclerotherapy. If they have that, I can use my laser quite safely to try and reduce some of their more visible telangiectasia. And varicose veins, this is, like I said, that scenario where people say, look, doctor, I know I need to get these larger veins treated, but really, can you do something about these purple veins? Well, if I'm going to do it safely, and it's still not a good idea to try and encourage this mentality, but you could do it pretty safely with a laser in terms of not causing any other larger venous complications. Now, which wavelength to choose? This is very important because if you're going to start to treat legs, you don't want to stay between the 400 and 600 nanometer range. because, like I say, you're not penetrating adequately enough. There's another problem with these wavelengths as well. They are very well absorbed by hemoglobin. In fact, they're too well absorbed by hemoglobin. So when you use a pulse dye laser, for example, at 585, what happens is when the beam hits the top of the vessel, it causes heating of the roof of the vessel. It causes quite a lot of heating of the roof of the vessel, but it only causes a thin layer of localized trauma to the vessel that is not enough to seal that vessel off. If you use a more poorly absorbed wavelength, such as the Nd:YAG, which does have a there is an absorption peak for this wavelength in the hemoglobin absorption spectrum, so it does actually get absorbed by hemoglobin, but it actually causes more of a diffuse heating throughout the vein that causes much more through and through damage through the vessel. So by far the best laser here for the treatment of leg veins is the Nd:YAG. It's also very poorly absorbed by melanin. Melanin is absorbs light very well in the 400 to 700 nanometer wavelength range. If you use pulse dye lasers and KTP lasers, you are much more likely to photobiostimulate the area and get pigmentation due to good melanin absorption. And that's not what you want. You don't want brown circles on the leg. So with the Nd:YAG, you're very safe because it is very poorly absorbed by melanin. So you cause damage to the vein, you don't cause much damage to anything else. You need to use a slightly larger spot size on the leg, something around 5 millimeters, which will allow adequate penetration. The larger the spot size, the better the penetration, but be careful, too large a spot size and you get tissue bulk heating, and then that can cause thermal damage and burns. So leg veins, yep.
Is 1 minute and...
Okay, well, I'll finish off quickly. All right, fine. So we've talked a little bit about the reasons why we select these lasers then. In my opinion, there's not really much of a place for pulse dye laser in the treatment of legs, so please refrain from using it. Treatment of matting and very superficial neovascularization that results from leg vein treatment is a use for that. So you can then perhaps help to expedite the resolution of that with a pulse dye laser, but not to treat other veins. Remember about your pulse width, because you have to tailor your pulse width to the thermal relaxation time of vessels, and obviously the diameter of the vessel dictates its thermal relaxation time, so you need to be aware of how to match those up, which you'll learn later on in the laser module. Now, this is just a quick final slide to finish on, because lots of people sometimes still come up and ask me this these days, Dr. Hussain, does laser work for leg veins? And I say, yes, it does. It works very well. But this is telangiectasia that I treat. This is one of my therapists who was getting very bothered by it. So straight away, it's a quick fix solution. Now, if that's not working, I don't know what is. But, you know, it's a very, very effective tool in the treatment of these problematic telangiectasia. So, you know, always seek to further your practice, add better ways of doing things, and clients like this because of its swiftness, the lack of bleeding, the lack of bruising, and the quick, immediate resolution that they get as well. So, you know, don't underestimate the power of laser and leg vein treatment. You'll often hear things said like, sclerotherapy is the gold standard. Sclerotherapy may be a gold standard, but combined treatment is even a platinum standard. So aim for platinum standards. Good. All done.